And I would like to call on Marta Skowronska, who's also from Warsaw. She works at the Institute of Psychiatry and Neurology, and she will present her data of the MPAN rating scale. Thank you very much.
Thank you for your invitation. I'm trying. Okay. And thank you, Suzanne, once again for your presentation, and thank you, the organizers, for the invitation. I would like to present the proposal of MPAN rating scale, because we are talking about the symptoms and we are talking about disease progression, and it would be easier for us, for clinicians, to assess the patients in some kind of scale. Scales are now widely used in clinical studies and clinical management of patients, because they can give us an objective assessment of the disease, of deterioration or improvement, which we are looking for. And in MPAN patients, we used dystonia scale and Parkinsonism scale, like UPDRS. But the MPAN patients, as Dr. Kmiec showed us, have an overlapping syndrome with dystonia, Parkinsonism, together with pyramidal signs, but also with optic nerve atrophy and cognitive impairment. So it would be better or easier for us to have a scale which covers all those clinical features. And more important, dystonia scales or UPDRS scale were not validated for MPAN patients, so results we are having from those scales might not be adequate, might not be objective for MPAN patients. So while preparing the proposal, of course, I looked for some inspiration, and there were two scales that I looked in, and the first one was the scale for the PICAN patients, which was published in 2017 in Movement Disorders. And the second scale I used actually was the scale used for Wilsonian patients, because Wilsonian patients are also treated in my department. And this scale also covers a lot of symptoms, as Wilsonian patients have also an overlapping syndrome, overlapping symptoms like MPAN ones. The scale is, well, we propose that the scale could be divided into three parts. The first part assessing the daily living activities, the second part where the cognition and psychiatric symptoms would be assessed, and the third part for neurological examination. And we will go briefly through the scale to show you what we have prepared. The daily living activities, like taking a bath or shower, grooming or toilet use, I'm sure you are all familiar with those questions, are to be assessed by the answers given by the patient and the caregiver, or by direct assessment by the rater. For instance, in the point 1, 3, 10 or 11, you can, during the examination, you can assess your patient together with the answers given by the patient and caregiver. All those items are divided into 5 different answers, where 0 is scored for normal, for no dysfunction, and 4 is for very severe impairment, where the patient or the caregiver says that the activity can't be done actually. The second part, for cognition and psychiatric symptoms, I tried to keep it very easy, because I'm a neurologist, and I would like to examine patients quickly and easily with the cognition. So the first 2 items are for so-called short-term memory, where the patient should remember and then repeat the words. I chose 4 words. And then after 1 minute, all the words should be recalled by the patient. Second, 2, that's number 3. I don't know why I can't see it here. Number 3 and number 4 are for so-called long-term memory. We call it also knowledge, because the patient has to answer the questions like, who is the president of the United States, or who is the president of the country, and name as many as possible animals in 30 seconds. And of course, here also patient scores from 0 to 4 points, where 0 is the best and 4 is the worst. The 5th point is the most complicated one, the most difficult one for the patients, because it is checking the so-called abstract thinking, conceptual thinking, because the patient is supposed to choose the word which is does not belong to the group of the words. He has to imagine the words and then choose the one which is not in the group. And to be honest, the patients have this is the most difficult part for them. Then the psychiatric symptoms, they are just to be asked and assessed during the examination, and we chose the mood, anxiety, behavior, like irritation, and here's also obsessive compulsive behavior. And well, from my experience with MPAN patients, the obsessive compulsive behavior is the most common psychiatric symptom in this group. The psychotic behavior is very rare in our cohort, in our group. And when there is no psychiatric symptoms, the patient scores 0, and for 4 or 5 psychiatric symptoms, patient scores 4. And then we skip to the neurological examination, and as you see, as Dr. Kmiec told us, the optic nerve atrophy and visual acuity is very important in MPAN patients. We tried to use both the Rosenbaum charts for assessment as well as Snellen charts, but the results were actually different for both of those charts. That's why we decided to use the Rosenbaum chart for the assessment and not to use both of them in the same time. And we find the Rosenbaum, as it's a pocket size chart, easier to examine the patient. Then we have the oculomotor function with nystagmus, loss of smooth pursuit, saccades, and horizontal and vertical saccades. And we go on to speech. We, of course, assess the speech during the whole examination, the whole of the patient, but in this part, we recommend that you can use your own language, French Desartia assessment, French Desartia assessment, and pick the words which are 1-syllable difficult, 2-syllable difficult, and 3-syllable word. And here is the example in Poland. In Polish, sorry, there are difficult words in Polish. I can read it to you. It's maszt, oszust I wiewiórka. And the patient, of course, has to repeat those words. Then we go on to facial expression and dystonia and hypomania, the tremor of the head and extremities, both rest tremor and postural tremor. And then the very important thing in MPAN patients, because they have spastic paraplegia or tetraplegia, then is the muscle tone to be assessed in the major joints. Then the clinicians using the UPDRS scale, you will find the finger tapping, hand movements, finger to nose test, and leg agility, which are taken from the UPDRS scale. And then we skip to dystonia, cervical, trunk, arm and hand and leg dystonia. And last are the pyramidal signs, which are also important in MPAN patients. So we assessed each extremity separately, and we score 0 for absent, 1 only for abnormally jerks, without pathological signs. So we score 1 if we find the pathological signs, but the jerks are not abnormally brisk, and 2 when we have both the pathological signs and jerks abnormally brisk. And now I'm afraid I can't show you the whole scale validation because we have examined only 5 patients out of 25 we were supposed to examine. We started the examination and the scale validation at the beginning of the year. Until March, we just examined 5 patients, and then through the pandemic, we had to stop. But I will show you the results from this group. The age, as you can see, was quite wide because the youngest girl was 12, the oldest boy was 23. They were all of Polish origin, of Caucasian origin, and we had 3 experienced neurologists assessing the patients. And what we have found is that the overall rater agreement was quite high because it was over 75, actually 76.3, the Fleiss kappa inter-rater agreement. So the agreement for the scale is good. And the internal consistency for the neurological part was nearly 1, with quite narrow confidence intervals. For daily living activity part, also quite hard narrow confidence interval and high internal consistency. So we hope that by the end of this year, we will be able to examine all group, the whole 25 patients, and to show you the whole validation of the scale divided into each item validated by and the inter-rater agreement calculated for all items used in the scale. So at the beginning of next year, I hope that the scale will be validated and ready to use. Thank you very much for your attention. That's all I have prepared for today.
Thank you very much, Marta, for sharing these data with us. I'm opening the Q&A session. Please submit your questions. How many patients are you planning to see?
25. So 5 is very low. It's a low number, and the scale is still not validated actually, so it can't be used actually.
And 25 will be enough for a validation of such a scale?
Yes, I think so. Well, we have performed the pre-analysis, and the 20 is enough, and 3 examiners are also enough. So for the validation, so we just put 5 more, and I hope it will be okay.
Thank you. Any other questions from the audience? We are in fact a few minutes early, so there's time for discussion. With regards to the cognitive feature, I know your memory, verbal fluency, and orientation. And then this last question with the verbal abstract thinking, how can you items?
Pardon?
On what basis did you choose these questions? Is this?
The words, yes, not, well, I had help from my neuropsychologist, and she chose the words based on tests she's performing on MPAN patients, and that's why we didn't, well, she also recommended not to use any tests requiring reading or writing, because we would like this scale to be used in children and in adults. So first of all, children might not be fluent in reading or writing, and the scale couldn't be used for them. And second, because the optic nerve atrophy and or let's say dystonia, hand dystonia, the patients might have problems with reading and writing. That's why we chose only the memory tests to be used in the scale.
Okay, thank you.
Thank you.
I think that's it. If there are no other questions, I thank you very much for this.
Thanks very much.
We hope that this scale will be validated soon and then available for all the other clinicians.